how do you work with preverbal pain if it's hard to recognize it, articulate it, or anything along those lines in the context of IFS? And the second question is, are there limits to IFS that you've seen, or how do we think about what's within the realm and what may be outside of the realm of potential of IFS?
So had I been sitting with you, I would have just had you focus on that blah feeling and get curious about it, and then ask where it was stuck in the past, and you might have come to that same preverbal place. And then, yeah, we do a lot with preverbal parts, and sometimes the witnessing isn't verbal at all. It's really just feeling the sensations of what that baby went through, or getting the emotions that he felt without a lot of visual even, or without words, and just doing that until he feels witnessed, and then going in and getting him out. So it's not a problem to work with preverbal parts. And even we go into the uterus, we work with prenatal parts.
Wow.
Sometimes, yeah. And what was the second question?
What are the limits of IFS? Can it go too far? For example, this is a question that actually came from Sanjay, who seems to have taken to doing the practice over and over and over again, and keeps uncovering parts, and maybe even taking it to an OCD level of uncovering parts. So, what are the limits, and what are any precautions that people may want to consider bringing into it?
The main precaution that I learned the hard way is to work with protectors first, not even expecting them to change, just to work with them to learn about what they protect, which is often these exiles, and then to negotiate permission to go to the exiles, rather than try to get to that pain or shame or terror right away and bypass protectors. And I learned that because I would work with clients and I would say, oh, I see there's a lot of pain, and we need to get to that. So we would get there, and then they would have these big, what we call backlash reactions after the session. I think part of the danger with psychedelics is that you can bypass protectors and get to exiles without permission, and then have a backlash. And then that scares everybody, including the facilitator. But if you think of it through the IFS lens, it's just a protector backlashing. So let's get to know it and calm it down and apologize to it for bypassing it. And everybody gets okay then. So it really helps to have this ecologically sensitive framework for this inner territory.
That's fantastic. I think it's great work. It's an area of interest, both from us at Field Trip as well as some of the other projects I'm involved with. So I'd love to pick up the conversation on those exercises, Dick, after we finish recording. But I did want to ask, I have tons more questions, but I want to respect your time, and I also have other things to get to. So there were two kind of broader questions, more philosophical questions that I'd like to turn your ear to. The fact that IFS is non-pathologizing, which, personally I think is important. And I'm just curious to know, how important is it in your mind that's non-pathologizing, and how does that stack up with the rest of mental health, which by and large seems to really like pathologizing? And, I think I follow someone by the name of James Davies on Twitter, and just showed the number of SSRI prescriptions and all that kind of stuff. And it feels almost destructive to make it pathologizing. Certainly, I think we're overdoing it, that everyone's got ADD or anxiety or depression or anything along those lines, and denying the fact that some of these are just part of the human experience and don't need to be pathologized. So curious to know your thoughts on that, and how it fits within existing frameworks, or at least the dominant framework in, I think, mental health.
Yeah, my position is sort of in between those two, because, as I said earlier, like, let's take depression. So the DSM accurately describes the symptoms. But for me, the symptoms are parts. There's one part that can flatten you out, so you don't care about anything and you don't want to do anything in your life. And it's just trying to keep you from getting hurt again. It's trying to keep you down so you don't take risks. And it's decided at some point The only safe way to do that is to make it so you don't care about anything. And then there's the critic who's yelling at you constantly for not doing things and buys into the whole belief system in our culture that you're choosing to be depressed and you should be stronger and all that. And then you got a bunch of raw exiles that would be hurt again if you did take risks in the outside world. And so we go to the depressed part and honor it for trying to protect everybody and negotiate permission to go to the exiles and heal the exiles. And now it doesn't have to be the depressed part. And then we go to the critic and help it out of its role. So it isn't that depression shouldn't be seen as a problem, like it's, just normal part of life. Now, clinical depression is a problem. And this is like you're saying, non-pathologized way to know exactly how to work with that problem. And the culture really does the opposite. And so much of what you're saying about CBT and so on is to try to talk the depressed part out of doing what it's doing, or to, medicate it out of that and not really heal anything, not really touch the exiles that are the problem to begin with. I'm not anti-medication. I'm anti-medication as the answer and the long-term answer. But there are times where you need that to get access to enough self to actually do some of this work.